Good morning. I'd like to thank the organizers for the invitation to speak today. My first talk will be on what's new in upfront mantle cell lymphoma. These are my disclosures. We've come to recognize that mantle cell is really a heterogeneous disease with approaches at diagnosis ranging from patients being observed without therapy to patients being treated with aggressive chemotherapy followed by autologous stem cell transplant. With our current therapies, we've improved survival in mantle cell lymphoma with the standard use of Rituximab, using high-dose cytarabine in induction therapy, consolidating with autologous stem cell transplant, and novel targeted therapies like the BTK inhibitors. However, despite our improvements in treatment, we know that patients with mantle cell lymphoma are most likely to die from mantle cell lymphoma. Not only that, we know that therapies that are aggressive are toxic with both short and long-term toxicities, and therefore there's a need to improve our outcomes and with less aggressive approaches. In 2016, the WHO described two different types of mantle cell lymphoma. One is classic mantle cell lymphoma, which presents like we think of lymphoma with nodal presentations, and these patients not always but often need treatment at diagnosis. The second type is leukemic non-nodal mantle cell lymphoma. These patients typically present with peripheral blood and bone marrow involvement and often will also have splenomegaly. Frequently, these patients can actually be observed without treatment for a while, and then once they have progressive cytopenias or symptomatic splenomegaly will require treatment. Historically, mantle cell lymphoma was a disease that was treated at diagnosis. However, based on Dr. Martin's presentation paper in 2009, we've come to recognize that there are certain groups of patients with mantle cell beyond the leukemic non-nodal ones who can be observed without treatment. They observed a group of patients that were not treated at diagnosis, and this was found not to impact their overall survival. Since his publication, there have been several other groups of people who have reported on groups of patients that were observed without treatment and found again that there was no effect on survival. These patients tend to be patients who have no symptoms, normal LDH, and low tumor burden disease. What to do with these patients when they do progress to be require treatment is yet unclear. However, this was a large retrospective study that looked at treating patients who were initially observed as we would if they could tolerate intensive induction versus less intensive induction, and found that there was no benefit when they progressed to requiring treatment to treating them with more aggressive therapies defined by cytarabine induction in consolidation with autologous stem cell transplant. This is perhaps indicative of the type of disease that they had, that these are just less aggressive diseases and will do well with a multitude of therapies. However, in general, mantle cell is still typically treated based on patients' age and comorbidities, with patients who are younger and able to tolerate aggressive approaches using aggressive chemotherapy consolidation with autologous stem cell transplant, and those who are older getting chemoimmunotherapy, possibly followed by rituximab maintenance. The use of auto was established in the first European mantle cell lymphoma trial, which recently reported 14-year follow-up showing an continued overall survival in those patients who received a transplant as consolidation. However, this was prior to the standard use of rituximab and high-dose cytarabine in induction therapy, and it's not clear that in today's therapies, all patients actually benefit from consolidation with autologous transplant. Probably the most utilized approaches in these younger patients are to give them either the Nordic regimen, which is our maxi-chop followed by alternating with high-dose cytarabine, or our chop alternating with our DHAB. Both of these have long-term follow-up available. So long-term follow-up of the Nordic regimen, which was the R-maxi-chop alternating with cytarabine. Median follow-up of over 11 years, it showed that the median progression-free survival in these patients was 8.5 years, with a median overall survival of over 12 years. At 10 years, over half of these patients remained alive, and nearly 40% remained in complete remission. While that's promising, you can also look, when you look at this progression-free survival curve, you note that there's no plateau in the curve, meaning that these patients continue to relapse over time. And it's not likely that we are curing patients with mantle cell lymphoma, even if they have prolonged remissions of greater than 10 years. The European Mantle Cell Lymphoma group that looked at R-CHOP alternating with R-DHAP also had long-term follow-up with a median follow-up of 6.1 years, showing similar median progression-free survival with the cytarabine arm of 9.1 years and median overall survival of over 12 years. Both of these established cytarabine, which is still used in induction in younger patients prior to autologous stem cell transplant. As I mentioned, it's not clear that everyone benefits from transplant. MIPI is prognostic for how patient outcomes with transplant, and it's been noted that in the transplant studies, patients with low-risk MIPI do better overall. However, what isn't clear is that if high-risk patients do better with transplant than they would do without transplant. So while we have no randomized trial with transplant in the Rituximab era, there was a large retrospective study of over 1,000 patients of over 20 different institutions that looked at outcomes in patients who were 65 or under treated with intensive therapy and transplant or treated with non-intensive approaches. And that retrospective study did show a progression-free survival benefit across risk groups to the transplant versus those who did not receive transplant. While the overall survival benefit did not reach significance, there were certain population of patients whose overall survival benefited by consolidation with transplant. And those include patients with high-risk MIPI and blastoid variant disease. So while overall these patients don't do as well as good prognostic patients, they may still do better with a more aggressive approach than a less aggressive approach. Maintenance after transplant, maintenance rituximab in older patients after R-CHOP has been shown to provide an overall survival benefit. And therefore, the role of maintenance rituximab after consolidation with autologous stem cell transplant was evaluated in this randomized trial. So these patients were actually treated with 4 of R-DHAP taken to autologous stem cell transplant and then randomized to rituximab maintenance after transplant versus observation. What was seen in this trial is that those patients who received further treatment with rituximab maintenance, given as 1 infusion every 8 weeks for a total of 3 years, or 18 total infusions, there was both a progression-free survival benefit and an overall survival benefit to receiving the rituximab maintenance, establishing this maintenance as standard of care in the majority of patients. While this has not been studied with all induction regimens, it has also been shown to be beneficial in other regimens after transplant with a progression-free survival benefit, although no overall survival benefit at follow-up. In the majority of patients, I would say that rituximab maintenance after transplant, so long as they can tolerate this, is the standard of care. The other topic in mantle cell lymphoma that's of high interest is minimal residual disease. So we know that patients who achieve minimal residual disease status with both their induction therapy or convert to it with transplant have a better progression-free survival than those patients who continue to be minimal residual disease positive. It is likely that at each step of the treatment, this is where you're seeing the benefit. So those patients who benefit from stem cell transplant may be those who still need to achieve minimal residual disease. And the benefit of rituximab maintenance may be in achieving minimal residual disease negativity and keeping it there. So the question remains, is patients who have minimal residual disease prior to autologous stem cell transplant, do they need the transplant or would they do just as well without? I mentioned at the beginning toxicities. There's certainly a concern with, while these treatments have improved median progression-free survival, looking at a median PFS of 8 to 9 years, they do come with toxicities, including febrile neutropenia or renal dysfunction. The R-hyper-CVAD regimen is a regimen that's been studied in this setting, and while it has similar progression-free survival benefit as these regimens, it does have a higher rate of secondary myeloid malignancies. A regimen of high interest in ongoing studies is the bendamustine-cytarabine combinations. We know that bendamustine is the therapy chosen in most of the older patients or patients who are not candidates for relapse. We know the importance of cytarabine prior to autologous stem cell transplant. This was data of 2 different trials looking at bendamustine alternating with cytarabine, or 3 cycles of bendamustine followed by 3 cycles of high-dose cytarabine, and then off-trial patients treated. This showed a very high overall response rate and a progression-free survival estimated at 3 years to be 85% and 5 years to be 80%, with high rates of MRD negativity, making this a regimen of interest for initial therapy. What about patients who are not candidates for stem cell transplant consolidation? So there have been a number of studies, both phase 2 and phase 3, looking at agents in these. I would say that by far the most commonly utilized regimen is the bendamustine rituximab, or BR regimen. And this was established, there were actually 2 randomized studies showing, looking at BR compared to R-CHOP or RCVP, showing a progression-free survival benefit to the use of bendamustine rituximab, which was overall better tolerated without the cardiac or neuropathy toxicities. R-CHOP is still commonly used. This should be used with rituximab maintenance. And then there was a randomized phase 3 study showing that BR-CAP had a significantly better progression-free survival and overall survival benefit as compared to R-CHOP. Recently published was long-term follow-up of the VR-CAP versus R-CHOP regimen, showing a significant benefit to both progression-free survival and overall survival in favor of the VR-CAP regimen. I think the one important thing to note about this study is that it did not use rituximab maintenance, and typically if R-CHOP is used as standard or initial therapy, it should be used with maintenance rituximab afterwards, as this is showing both a progression-free survival and overall survival benefit. How long do you use rituximab maintenance? So long-term follow-up of the study evaluating R-CHOP followed by rituximab versus interferon maintenance with a median follow-up of over 8 years showed a median progression-free survival of 5.5 years and a median overall survival of 9.8 years when rituximab maintenance was used. In this study, patients received rituximab maintenance for a minimum of 2 years, but were allowed to continue until progression. And what it did show is that not only did maintenance rituximab provide the benefit, but the longer patients receive maintenance rituximab, the better the outcome. So there was a significant difference both between patients receiving for more or less than 2 years and more or less than 3 years in both the progression-free survival and the overall survival benefit, suggesting that this may be a good approach to continue as long as patients aren't having infectious issues. So questions in the frontline setting remain. Do all transplant eligible patients benefit from transplant? What is the role of maintenance? What is the role of novel targeted therapy? Is there a role for minimal residual disease-based therapy? And how do we best minimize toxicity while improving survival? There are a number of ongoing studies trying to answer this question. The European Triangle study is a randomized trial looking at their standard approach with R-CHOP or DHAP followed by autologous stem cell transplant, and comparing that to that approach, adding in ibrutinib, going on to transplant, and then ibrutinib maintenance, or that approach with the addition of ibrutinib, no transplant, and then ibrutinib maintenance. So this is looking at both the role of ibrutinib in the frontline setting in induction and maintenance, and the role for autologous stem cell transplant in the area of novel therapy. There is a randomized phase 3 study ongoing across US sites, and this is looking at using minimal residual disease negativity, or MRD, to decide treatment. So as I mentioned, patients who achieve an MRD negative state, we know that they have prolonged progression-free survival. So this takes patients after any induction therapy and evaluates their MRD. If they're MRD negative, they're randomized to autologous stem cell transplant followed by rituximab maintenance, which is a standard, versus rituximab maintenance alone. This will hopefully help to answer the question if those patients who achieve an MRD negative remission really need that more aggressive treatment with autologous stem cell transplant. And the last is a randomized 3-arm phase 2 trial ongoing in the U.S. to look at what is an ideal regimen to achieve MRD negative complete remission in the frontline setting in those patients who are eligible for transplant. This trial is evaluating 3 arms that uses the backbone of that bendamustine rituximab along with high-dose cytarabine regimen, and then looks at the addition of acalabrutinib to that regimen, or looks at the BR regimen with acalabrutinib alone and no high-dose cytarabine, which is really looking to evaluate or understand the role of both novel BTK inhibitor therapy in frontline treatment and the need for cytarabine when you use these novel agents. This was in patients who are not candidates for transplant. We await the results of this randomized study, which looked at the role of adding bortezomib into the frontline or induction treatment in addition to BR, and then the role of rituximab maintenance versus rituximab and lenalidomide maintenance to really see if there's an improvement both of addition to the BR and then addition of novel targeted agents beyond rituximab maintenance. Other ongoing trials that have the potential to change the way we treat these patients. We await results of the phase 3 SHINE trial, which was a randomized trial looking at bendamustine rituximab followed by maintenance rituximab versus bendamustine rituximab plus the BTK inhibitor ibrutinib followed by maintenance rituximab and ibrutinib, again to look at the different role of novel therapy in the frontline treatment and also the role in its maintenance. The ENRICH trial, which was R chemo plus maintenance rituximab versus R ibrutinib and ibrutinib rituximab, BR acalabrutinib, so a newer BTK inhibitor, and then the European MCL trial, which looks at RCHAP versus RCHAP-R had, and then maintenance rituximab versus rituximab and lenalidomide maintenance. There was a phase 2 trial that looked at rituximab lenalidomide as upfront therapy in patients, showing very high overall response rates and 5-year progression-free survival similar to that of what we see with chemotherapy. However, this only enrolled about 30 patients, so we need a lot more patients to understand the role of this therapy, but it is an idea that non-chemotherapeutic approaches may have good efficacy in some of these patients with mantle cell lymphoma. Rituximab ibrutinib has also been evaluated in this setting in a couple of different trials and showing, again, very high overall response rates and good median progression-free survival with longer follow-up of both of these needed. And ongoing trials include looking at the role of additional agents, so rituximab, lenalidomide, acalabrutinib, to see if this can further improve outcomes in these patients. So in summary, our goals of treatment in upfront mantle cell lymphoma are to improve survival while minimizing toxicities. We need to identify patients appropriate for observation, which will be about actually 20% of patients who are initially diagnosed, and not expose them to the toxicities of therapy if they can be observed for a time. They also may be patients that when they do require treatment, do not need as aggressive as an approach. We know that consolidation with autologous stem cell transplant improves progression-free survival, but it's unclear that this benefits all patients in the area of our current therapies, and things like minimal residual disease may be able to play a role in determining what patients benefit from these therapies. Maintenance rituximab improves overall survival in all settings, so in younger patients post-autologous stem cell transplant and in older patients, particularly after R-CHOP chemotherapy. Incorporating novel therapies into frontline regimens is of high priority, both in combination with chemotherapy as non-chemotherapeutic approaches and looking at their role in maintenance therapy. And hopefully we'll be able to use minimal residual disease to guide future therapeutic decisions, including who needs more or less aggressive approaches, and even to decide how we give maintenance therapy. Thank you.